Hello. Hello. Thursday night instead of Tuesday night. Sorry about the change of night. Had a bit of a thing on Tuesday night. I was on the train. Didn't think it would be advisable, and it wouldn't have been advisable to do it on the train. I'll tell you now. I toyed with the idea. I see YouTubers doing it in public, but I don't think I would have. I don't think it would work well in public. To be honest, I think this. What's the word? This model, not the right word. I think this model really needs to be in an enclosed environment. I don't think it works on a public arena. So, hello, Zoe. Nice to see you here this evening. I am going to be doing some questions which I've got, and if you've got any questions, anyone, please ask away. And I will. I don't know if I'm supposed to do that. I will definitely answer them if I can. And Natalie's here. Hi, Natalie. And I. Sorry, I made it wobble. I'll try and stop it wobbling. Oh man, did I? Yes, I did. I have got some pre-done questions here, which I'm going to go through at my leisure. Sorry, I'm wobbling. I'm going to stop. It's going to stop wobbling in a minute. I can assure you of that. No, it's because I'm typing. I'm stopping typing. Typing has stopped. So the questions. Come on, save. Yeah. So we got a question here, which says, "Hi Rachel, nice to see you. Is that sorry? It's still wobbling. Is there an airport near your surgery/stroke clinic? I'm in Belfast, but finding it very difficult to find a surgeon here with online reviews." So this is this. I said I'd talk about this question because not to tell you whether there's an airport near the surgery clinic, because I could answer that bit of the question, but the wider question about that. So in general terms, it's interesting because the area that I'm in Birmingham is called the Edgbaston Medical Quarter, and they're trying to make it like a Harley Street. And it has actually got, because Harley Street has a lot of people from all over the place who come and have treatment in there, obviously, and they rely on a lot of overseas people coming to have treatment there. And they're trying to encourage that in the Edgbaston Medical Quarter. And in answer to the question, it is very well set up for communications. Birmingham has got a really, really good setup. It's a lot better than London. I mean, you fly to Heathrow, you're miles away, and Gatwick, you're miles away from London. So there is actually an airport, Birmingham International Airport, and then there's a little monorail which links the airport to the train station, Birmingham International Train Station. I think it's 19 minutes to the train station to New Street, which is right in the centre of Birmingham. And then the clinic is about 5 or 10 minute taxi drive from there, or there's a train which you can get to goes to Five Ways, which is one stop from New Street, which is a few minutes, and then you can actually walk from Five Ways. So yes, we are near a airport and train and everything like that. We're quite central in Birmingham, but the reason I wanted to talk about this is because this patient is in Belfast, and I think she said she's seen 3 surgeons already in Belfast. I mean, I would say that I always tell people that, not to travel, really. So that's why I'm not really very good advocate of this thing that Calthorpe are trying to do, and Edgbaston Medical Quarter are trying to do, where they're trying to encourage people to come from overseas, because I would always say, you try and have surgery closer to home. I think there are some countries where there isn't great medical care, and I think that's why people come here. So I guess if there are reasons like that to come, then that's fine, but you have to stay around for quite a long time to make sure that you're looked after, and also you have to make sure that you've got facilities to look after people when they go back home. So and which is something that we're not really set up for. And so I would always advise people really to have surgery close to home, and there are lots of good surgeons in Belfast. BARP's website, BAAPS, the BAPRAS website, BAPRAS. That's a list of plastic surgeons. And I would say to you, try and see someone close to home, really. You're very welcome to come and see us, but and we'll do the surgery, and I'll say to you, stay around for a bit of time afterwards. But the problem is all the follow-ups. I mean, we can always do them on the phone or Skypes and things like that, but it's never as good as coming in person follow-ups. And what if you have a problem? If you have a little dog ear, or if you have a little bit of infection or something like that, we'll say, "Oh, come and we'll check it out at the clinic." It's just difficult if you're in Belfast, and I have operated on people who've come from far away, but I've said this to them before operating on them. I always say, look, it can be a bit of a thing, and we haven't had any big problems, but it's just a bit of a worry to me if you're in, even just sort of like Essex or Scotland and things like that, when we get people coming down. So I do say, look, there are good people around in all areas. Good friend of mine is called Colin Morrison. Actually, he's in Dublin. I know it's not Belfast, but I'm sure there's good people in Belfast as well. So yeah, so the answer is yes. There are airports and stuff, but it would be advisable to have it done in local to home, is what I would say. Just because of the follow-ups, and if you need another operation or other procedure, we're going to do it in Birmingham, so you'd have to come back to Birmingham, and if you stay overnight in the hospital, and if your family and all that's in Belfast and things. But I don't want to put you off. I probably am putting you off, but yeah, I'd probably just, if it was me, I'd probably rather go closer to home than having to travel a long way to go to the hospital and to go for the follow-up appointments and things. So yeah, that's why I put that question in. Well, that was helpful. Right. Oh, what's going on? Oh, my Lord. What's going on here? Sorry, I missed this. Hannah's here. Long time no see, Hannah. Where you been? Hannah, are you coming to the clinic to see me sometime? I haven't seen you in ages. JTig, Donetta, I haven't seen you in ages. How you doing? Good to see you. Khan's here. Look at this. It's all kicked off in the chat while I've been chatting away. Sorry, it's wobbling. I haven't really... Anyway, I'm not going to talk about my IT. But anyway, yeah. Yeah, nice. Look at that. It's all go, isn't it? Thursday night. Done well. Is Thursday night better than Tuesday night? Comment in the chat. That's what they say, isn't it? Comment in the chat if you think Thursday night's better than Tuesday night. Okay, don't. Do you offer TT, tummy tuck with lipo and breast lift at the same time? There's a reason. Yes, that's right. I know what I want to talk about here. So yes, that's normal. That's what I want to talk about. So tummy tuck and liposuction and breast lift, that's a normal, that's a not uncommon combination. Mummy makeover, tummy and breast is a common thing to do. The thing I wanted to say about the liposuction is it is very common to combine liposuction with a tummy tuck. It's a standard thing to do. But one thing you've got to think about, because I've had a couple of patients talk about having liposuction, and one thing you've got to think about is where you do the liposuction, because where you usually do the liposuction at the time of a tummy tuck is on the sides, the flanks, the hips, the sides. Some people want it in the upper abdomen. Try not to do liposuction to the upper abdomen, because it can affect the blood supply to the skin, that and the heat can affect the healing. But the main thing is if people want it around the back. Sometimes people like around the back, the sort of bra folds over the back of the bra and what have you. And what I try and get across is you've got to try and think of how you are in the operating theatre. So you're lying flat on your back with your arms out on the operating theatre, and we have to clean and prep and drape you. So we have to sort of prepare your skin. We paint your skin with antiseptic, and then put sterile drapes, which are adhesive drapes on, and you operate within that sterile field. So you can't get to the back while you're prepped and draped, sort of lying on your back like that. You can't get to that bit of the back. So although you might think, oh, I've just got a bit of fat here around the back I'd like to have fixed, it makes it quite difficult, because what we have to do is we have to roll you. We have to roll you on your side and then do some liposuction. And if you want both sides done, we have to roll you on one side and then roll you on the other side. We can put you on the front and do both back and then put you on your back again. But the anaesthetists don't like anaesthetic on the front for long periods of time. So we can do that, but either way, getting technical now, either way, it can involve some kind of turning, basically. So 1 or 2 turns, and that increases the complexity. So if it's a bit of fat that we can get to while you're lying like that, it'll be a lot easier than if it was on your back, basically. So if it's the hips, the flanks, the outer thighs, some anything in the anterior aspect of your body, the front aspect of your body, it's a lot easier than when it's around the back. So I do feel a bit sorry when people say, "Oh, just a little bit of lipo here," and it's like, "Oh, well, that's really tough. Actually, better to just do that on its own another day, really, sort of thing." And I think, well, it can be done. So it can be done. It's not like it can't be done, but it is a little bit tricky. Hannah is good. I'll get booked. Yeah, get booked in. You couldn't make the last one. No problem. I'm well, Hannah. I'm very well. Been lovely to see you. So, Gemma, I'm still really interested. That's good to hear. Gemma is still interested. I haven't put her off. Can you send me the finance options? Yeah. So what we'll probably do is reply to the chat, I think, Gemma. We'll do that tomorrow. And if you, yeah, we'll do that. Finance. I mean, basically, the finance is usually done through the hospital, and it's 12 months interest free. Actually, is it? Or was one of them 10 months? Anyway, yes. The point is, we will do that. We will get back and do that, Gemma. That's good to hear that you're still interested. So we've got a question here which says, is it possible to have an areolar reduction at the same time as a BBA? Again, another question which I'm going to lead on to talk about something else. I'm using the question as leverage. So a BBA, breast augmentation, and an areolar reduction. Yep, that's possible. Absolutely fine. No problem whatsoever. Maybe I should have used the other question rather than using this question, because this question is a plain yes. The other patient we've had this, or was it this week, recently, who wanted a mastopexy, a breast lift, and an inverted nipple correction. And when you do a mastopexy, you're moving the nipple, and there's a risk that you can alter the blood supply of the nipple, and there's a risk you can invert the nipple, it can get pulled in. So we're a bit worried about the nipple when we're doing mastopexies and breast reductions, because we're moving the nipple. You're not moving the nipple with a breast augmentation, but with a mastopexy or a breast reduction, you are moving the nipple. And so I would be a bit worried about doing an inverted nipple correction. I'm answering a totally different question here. I'm sorry about this, because oh dear, sorry. So an areolar reduction is actually part of a mastopexy or a breast reduction. So if this person said, "Can I have an areolar reduction at the same time as a breast augmentation?" You know what? I'm going to do it separately. So is it possible to have an areolar reduction at the same time as a BBA? Yes, it is. Yeah. But if you'd asked the question, and I'm not making this up because someone did ask this question, can I have inverted nipple correction? I should have areolar reduction and breast augmentation, no problem. Areolar reduction and mastopexy or breast reduction, no problem, because that's actually part of it. You don't even have to ask for that. An areolar reduction is integrally part of a breast reduction or a mastopexy. But if you ask, can I have inverted nipple correction? Not if, someone did ask this at the time of mastopexy. If you ask me that question, now that's something else. If you ask me, can I have an inverted? That's different. Inverted nipple at the time of a mastopexy. Because you're moving the nipple with mastopexy and breast reduction, you worry about the nipple vascularity. So so the answer to that is no. I probably wouldn't do an inverted nipple correction at the time of a mastopexy and breast reduction. But then this patient has said, not unreasonably, if she'd had the mastopexy and the inverted nipple correction at the same time, there would have been a discount. There's a 20% discount of the cheaper procedure. When you have 2 procedures, there's a 20% discount of the cheaper procedure. So basically, it's cheaper if you have 2 procedures at the same time. And she wants 2 procedures at the same time. And then she's saying, and we're saying, no, we can't do that. So she's saying, well, look, if you do the inverted nipple correction separately, will it still be cheaper? Because it's not my fault that we can't do it at the same time. And I totally understand that, and my sort of gut feeling and my, I would like to say yes, we can do that because it's not your fault. We can't do it at the same time. The problem is, and I don't want to look like we're being sort of ungrateful for people's custom sort of thing, because we are very grateful for people's custom. The problem is we are all members of BARPS and BAPRAS at the clinic, which are plastic surgery, not and or, because I think me and Kuram are BARPS and Azam is BAPRAS. Well, I'm BARPS and BAPRAS. But anyway, never mind. They're both the big plastic surgery associations. And we have a code of conduct, and we cannot incentivize surgery. Now, you might think we're incentivizing surgery by saying if you have 2 procedures, we get a 20% discount. But the reason we do that is because it's cheaper, because you open one pack, you have one hospital stay, so there is economy of cost with the hospital consumables. We're not doing it to incentivize the surgery. We're doing it because it actually costs less to do, to do 2 operations. Like if you're taking off 2 moles, it's a much less price than doing 1 mole, because you open one, if you open one pack. So there's a reason for it. With this patient, if I'm doing the inverted nipple, I say it'll be Kuram, but if we're doing the inverted nipple at a different time, although I would like to say, oh yeah, we'll give you a discount just the same, that would seem to be incentivizing the surgery. And I think BARPS would take a dim view of it, and it would look like I'm trying to say you'll get a discount if you have the inverted nipple correction. So I can't do it. So we can't do it. So we have to charge you full price. And I know that sounds mean because you wanted it done at the same time, and I do feel bad about it. So I just want to get that off my chest, really. I don't know if this patient even knows I'm going to talk about this today, and whether we can tell her afterwards, because I just want to explain that situation, because I'm not sure if they explained that to you when they told you that. You said could have it less. I said I think it wouldn't look good if we started offering things less like that. We can't incentivize surgery. We can't give discount. I know that you go to these cosmetic clinics and they say £500 off if you have it this month. We cannot do that. It's not that we're trying to be like hoity-toity or anything. We cannot offer incentives, time limited offers. We cannot say, hey, book it this month and you get £500 off. That is against the code of conduct of the professional associations. If you're not a member of the professional associations, you can do whatever you want, but if you are a member of those professional associations, so people who are BARPS and BAPRAS members cannot make offers. We cannot do buy one get one free, or anything like that, because it's a medical procedure, and it is not something that we can sort of discount things. Oh dear, got a bit heavy there, a bit heavy. Oh, sound has what? Oh god, the chat's kicked off again. Focus. Hi, I'm considering having a tummy tuck. Is it best to have glue or stitches and drains? Donetta's saying sound has reduced. Donetta, was that because I put the mic down? It was a mic drop, Donetta, because I was typing. I'm all over it now. So Sonia, I am I've seen tummy tuck using glue or incision and no drains, or would you think stitches and drains better to have fur build up to come up? Yep. Is it best to have glue or stitches and drains? So Sonia, what you'll find, particularly in plastic surgery, but also in particularly in plastic surgery, but in a lot of surgery, there's no better. I'd always be a bit wary about someone who says something's better. Well, there is some better stuff, isn't there? Anyway, if there's some people who do it one way and some people who do it another way, and the people who do it one way says it's better doing it their way, you've got to question why the other guy's doing it the other way. Is that making sense? So basically, there's not better. It's like a teardrop implant's better than round implants. Is it better to have them under the muscle or over the muscle? Is it better to have a mini tummy tuck or a full tummy tuck? It's like there's good and bad about both of them, and they all exist. So drains, and so it's a big area. Well, it's not a big area, but it's a big sort of controversial thing that splits plastic surgeons: drains or no drains, basically. Drains or no drains. So that is a big issue, and I've got to say we are moving towards no drains. We are moving towards no drains, and patients don't like drains, and a lot of operations we're doing with not doing drains when we used to do drains. Tummy tuck, and I was just talking to Kuram last night about it, and I was saying we still use drains for tummy tucks. And before a while ago, it was the glue and the glue or drains, and the glue's like, oh, they used to do that in the back when they do the back operations. I'm going to talk about seroma. This will tie in to a question later, because what we're talking about here is seroma prevention. Seroma comes when you've got a big space, and I don't want to mess up my later question, but the point is that there's a space there, and that space can fill up with fluid. So you need to close the space, and the drains are suction drains, so they close that space down. So if you're not going to use drains, you can think, what can I do to close that space down? And the other thing they do is they use drains. Some people use drains. Now, I'm not saying that's right or wrong. They get good results with the glue. And I've used glue and it's been fine when I've used it, to be honest with you. But for me, it's a bit of a palaver to use it. Because you have to stick down the skin flap and you have to put your stitch in a special way. And you have to then tighten your stitch, and you've got a few minutes while the glue sets to get your stitches in. And it's all a bit of an art, really. And it's something that's, I don't particularly like it, this sort of rush to get it all closed, because you only got a few minutes while the glue sets. So you've got to get all your stitches in place and everything. So it's just, I never really embraced it. The other thing that worries me is the patient will wake up and cough or move and turn, and that glue will shear, and the space won't be stuck down. And when they say about it, they say, oh look, it's really good low seroma rate with the glue. The seroma rate, I mean, I've had one seroma for a tummy tuck, which was about, it was Christmas. I remember it was Christmas. Always happens at Christmas, but it must have been 4 years ago. So seromas are very rare with tummy tuck when you use drains. So I really haven't got a problem with seroma. So that's what worries me about not using drains. But the other option is using quilting sutures, which we have started to embrace. And I was talking to Kurum about it last night, actually. And I think quilting sutures, so what we're doing at the moment is doing quilting sutures, so closing down the pocket a bit by putting stitches deep to close down the space, and using a drain, but looking and seeing, look, there's less in that drain. Can we start to move away from using drains? So we still do use drains, but we're looking at ways to reduce the use of drains. And I think quilting sutures I prefer personally to glue. But I think there's no right or wrong. And if you find a surgeon who's got good results, who's got happy patients, who's using glue, go for it. If you find ones who's using drain, I mean, people don't like drains. I don't, you'll think it's nothing. No one will say that the drain was a good thing. It's uncomfortable and people don't like them. So I would like not to use drains, but they serve a purpose, and I think they are useful. And so, yeah, I thought that's answered. Yeah. So, yeah, that's what I do. I've seen tummy tuck using glue on incision and no drains. So, Sonia, I think the glue that they're using is not on the incision. The glue is deep underneath to stick down the skin flap. They spray it underneath to stick down the skin flap. Glue on the incision is different. You can use glue on the incision, but that's different. That's not the glue when people are talking about using glue in tummy tucks. The glue on the incision is just to seal the wound if they don't want to use a dressing or something like that. So I think it's not the incision they're putting the glue, or they might be putting all the glue on the incision, but that's not what they're talking about if they're using glue instead of drains. The glue goes inside to stick down the skin flap. You really need to see it. You need to see a tummy tuck. If you saw a tummy tuck, you'd understand it. It's quite hard to explain. I don't know if I'm doing a good job here. Lisa says, good evening, Jonathan. Hope you are well. I'm very well. I am very well, Lisa. Thank you for asking. Gemma, how do other surgeons get away with offering discount to repeat patients? So what that happens, Gemma, is what I mean, it's interesting this. I wrote about this in my book, because this happened to me. You see, what happened, I had a situation. I don't know if I want to get into this. It's a bit of a long story, but anyway, I saw an accountant. They sent me a letter, and anyway, I had this thing, and this accountant came to see and said, "Oh, I want to be your accountant," and all this thing. And he said, "I'll do a free thing where you talk to you for ages." And he talked to me for ages. Came around the house. He wants to know about my life insurance. Oh God, stuff like that. And then he wanted to come back another day, and he came back another day, and went through. I was here for ages and ages, and then eventually left. And I'm about to go to the cinema with the kids, and I was thinking, I'm going to be late for the cinema. Oh, God, come on, man. It's the second day he's been here and he left, and made me sign all these forms, and I didn't really feel comfortable with that. It's all a bit, oof. Anyway, then I thought about it. I thought, actually, you know what? I don't really want to be with this accountant. I thought, I'm not really happy with that. So I said, you know what? I don't want to do this. And then he sent me a bill for £700. And I'm like, what? He sent me a bill for £700? Why? He said it was a free check, And he said, well, that was the first consultation, was a free one. and the second one was £700. I'm like, I didn't even want the second one. I couldn't get rid of you. I can't believe this. So I said, right, I'm going to go to the Institute of Accountants because I think that's bad practice. You can't charge someone £700, especially since I didn't know you were going to come back. I didn't want you to come back, and I didn't know you were going to charge me £700. You've got to tell people. And then they said, well, he's not a member of the Institute of Chartered Accountants. I'm like, what? I mean, he's an institute. I mean, I don't be libelous to say what he was in. I can't remember now, but the Institute of Financial Advisors or something. I don't know what he was. The Institute of something. And it turns out there are two institutes. I can't remember what they were now. It's like the Institute of Chartered Accountants and the Chartered Accountant Institute or something. There's two official sort of things for chartered accountants, and there's all other things which. So if they're not a member of those the proper institutes of chartered accountants, you haven't got anywhere to go to sort of complain. They're just like a member of the public, really. The point I'm trying to make is that it's the same for plastic surgeon. There's two. There's BARPS and BAPRAS. Those are the two associations. You have to be a fully trained plastic surgeon to be a member of those associations. And there are a lot of people doing plastic surgery who are not fully trained plastic surgeons, who haven't got the FRCS PLAST, who can't be members of BARPS and BAPRAS, and they're doctors. I mean, they're doctors, but they aren't really bound to the same code of conduct that we have as members of BARPS and BAPRAS, and they're not held accountable. We have to present our figures every year to BARPS to show that we've not got lots of complications and that we're doing things within our scope of practice. Because if you're a surgeon in one area, you're not supposed to operate on other areas and things. So we're held accountable by that. If you're not a member of those associations, you're not held accountable. So you can you can say £500 off if you book this month. What did you say? Discount to repeat patients. Come back and we'll go give you a special offer and all that sort of stuff. Because if they're not members of BARPS and BAPRAS, they're not accountable to that code of conduct. So they're just really accountable to the GM. They're still accountable to GMC if they're a doctor, but you'd have to do something. GMC is not quite as tight as the BARPS within terms of advertising and offers and things. And then obviously, other than that, if they haven't got the same sort of. So, and similarly, if they did something you thought it was bad, you can't go to BARPS and BAPRAS because if they're not members of BARPS and BAPRAS, they can't do anything about it. So good, thank you for that. Good question. So that's how that works. But and it does happen a lot. And it's sort of, I don't want it to make us look bad because we don't ever do that. We can't do discounts. Can't do a discount for cash. Can't go to discount. Well, we do a discount as if you have two procedures for the reasons aforementioned, but we can't say your friend comes, we'll do a discount for your friend or something like that. So that's what it is. I've been researching and I'm not sure. I've not booked anywhere. Just worried about seroma. Sonia, you worried about seroma? I'll tell you what, Sonia, a tummy tuck is a big operation and there's stuff you should worry about. I wouldn't put seroma up there because even if you get a seroma, to be honest with you, it's not that bad. You just have to drain it. You just have to put a needle and drain it. So actually a seroma is not a disaster. It's not very nice. You can get long-term problems with seromas and you hear nightmares with seromas. But if you do get a seroma, it's usually pretty easy to treat. So I wouldn't actually make seroma a big deal breaker, but I think it is. Tummy tuck's a big operation with potential complications and scar and recovery and all that sort of stuff. So it is a big op, but I wouldn't make the seroma being the big thing you worry about, and I wouldn't focus too much on this glue and drains thing. I'll call you to book a consultation. Thank you. Whoa, look out for your call, Sonia. Very good. Oh, okay. Thank you. Debbie, good evening, Jonathan. Many PS plastic surgeons in the UK don't like doing lipo with tummy tuck due to the blood supply and skin surviving, I'm informed. How do you achieve a good body shape without it? I wouldn't have thought muscle repair and tummy tuck alone would achieve good results. Debbie, good one. You are on it. You know what you're on about there. And that's sort of what I was alluding to earlier in terms of the liposuction. I think you'll find that it's not that they don't like doing lipo with tummy tuck. It's the area that they do the lipo in. Anyone would do lipo to the hips and flanks. It's standard to lipo to the sides to help contour the sides. The problem with doing lipo with a tummy tuck is doing lipo to the upper abdomen, the sort of bit underneath the breast, because a lot of people say, I've got a bit there, can you just do a bit of lipo there? And that's where we worry about doing lipo, because as you say, it does affect the blood supply. Because again, if you saw a tummy tuck, you would see that the skin from the belly button to the pubic area is all removed, and the skin from the belly button to the rib cage is pulled down. It's undermined and pulled down. It's undermined. I don't know if you know what I mean by undermining. You sort of go underneath the skin and the fat, and you go on top of the abdominal wall to make it have some give, and then you pull it down to the pubic area. I've just done a blog post on Monday about this. That's because people wonder what goes on with the belly button. And sometimes if you look at moles, you can see that moles used to be in the upper abdomen, then end up, moles that used to be way above the belly button end up below the belly button or right next to the belly button, because that skin gets stretched down. And because that skin gets stretched down, that's where all the blood supply comes in from the top, because you've undermined it. You've released it from the abdominal wall. So you've released all that blood supply. So all the blood supply, that skin's coming from the top. If you then stick a liposucker in there and start liposucking that flap, that skin flap, it's called a flap because it flaps about, you worry about interrupting the blood supply. And one of the worries of tummy tuck, as I say, seroma, I wouldn't say is a big worry, but wound healing is a big worry with tummy tuck. You've got to get that wound healed. It's under tension. It's really tight. That's the whole point of a tummy tuck. That's why you mustn't smoke, things like that. But it's a worry for us to get that wound healed. So a lot of surgeons and many plastic surgeons don't do upper abdominal liposuction at the time of a tummy tuck. So that's the area. So, but I've got to say, you don't often need it because its skin stretches. So you often don't need it. But if you really did need it, you would have to have it at a later date. So sometimes you have to say, look, and again, you have to pay again and all that. It's terrible. But you have to come back at a later date. And then you can do liposuction 6 months later. You can do liposuction to the upper abdomen. But it's not very safe to do it at the same time as the tummy tuck. But it's upper abdomen is the lipo that people worry about when you say plastic surgeons not doing it because they're worried about the skin surviving. I hope that's... Oh, I've lost. Oh, I've lost you. What do you mean you've lost me? You mean you've lost me because you've lost signal, or I've not made any sense? I need to show you in real life, really, don't I? Yeah, I can't need to. Anyway, the point is they won't do it to the upper abdomen, Debbie. Have I not made that clear? What we need to do is we need to get video in theatre, and I'll show you in theatre, and I'll doing it and saying underneath, Anyway, that's where they won't do lipo, upper abdomen. Made that clear. Sorry, other question. What's involved for inner thigh lift? Does it remove excess skin due to 6 stone weight loss? Whoa! Fantastic. Congrats on the weight loss, number one, Sonia. Yes, it does, Sonia. And so body contouring procedures usually are really the main thing about body contouring is the skin, the excess skin. You do remove fat, but the main thing is the skin. That's why tummy tucks are so good, mastopexies, facelifts, they all remove skin and tighten that skin. And the inner thigh lift, there's 2 ways of doing it. There's one where you make an incision in the groin. That removes skin in an up direction, in a vertical direction. I'll probably lose you now. I'm going to lose. Getting too tell. I need to have a whiteboard. I have a whiteboard behind me. So anyway, there's a thigh lift where you do it in the groin. Personally, I don't like it. It doesn't give much of a pull. If you pull it yourself, it doesn't give much of a pull. A hidden scar, but it's not a nice scar. The scar can stretch. It can have effect on your sort of, on that area. Can pull on that area, and we're below the watershed. So and it doesn't give a good pull. So in my hands, the thigh lift up in the groin is limited to how it can pull. If you demonstrate to yourself what you want done, you will pull in a vertical in a sort of longitudinal direction down your thigh. That's where you want the skin tightened. So the best way to do a thigh lift is to make a big scar right from the groin right down to the knee on the inner aspect of the thigh, a bit like the arm. We try and hide it by putting it on the inner aspect of the thigh, but it's a big scar. If you're in shorts and stuff, you abduct your hip. If your leg sort of swings out, you will see a big scar there. So that's the best way to do a thigh lift. It's a big scar, but it's only for people who've had massive weight loss. So you may be a candidate if you've got a lot of excess skin there. But that's just a thigh lift. Again, it's a big op, complications and what have you, because the skin's under tension. All this body contouring surgery, the skin's under tension, wound healing and what have you. But that, in my view, is the best way to do it. But yeah, obviously you need a consultation and all that sort of stuff. But that's the sort of 2 ways of doing a thigh lift. Yeah, I shouldn't really say it's the best way of doing it because I've just said earlier, don't listen to people who tell you there's a best way of doing it. Anyway, it's more of a lift with that one. Right. Mariana, what determines the maximum amount of fat transfer to breast? When do you know you put too much or can't fit any more fat? Good question, Mariana, and it's really interesting. And I think probably people think, the public think, there's more of a science to this than there is, but there isn't a science to this. And the two aspects of fat transfer are donor sites, so where you can take it from, how much fat you've got on your body to take it from. Usually people who are having fat transfer to the breast are slim, usually, because it's usually for something like a breast augmentation. So someone wants a breast augmentation, they don't want implants. Perfectly reasonable, don't want implants, no problem at all, can use fat transfer, but they're usually slim people. And so the donor sites are often limited. So where you might say, oh, I've got loads of fat, but actually, I haven't got much fat. But you can take it from anywhere: abdomen, hips, thighs, outer thighs, things like that. So that's number one thing. And number two thing is, the other thing that limits it is the recipient site, so the breast. Because what you're trying to do is, you don't really want to inject the fat into the breast tissue itself. You have to inject it sort of underneath the skin, between the skin and the breast, and also beneath the breast, so between the breast and the muscle. So you have to sort of surround the breast with the fat, and you have to put the fat in tiny little aliquots, because each little piece of fat has to be surrounded by vascularized fat. So you only put in tiny, tiny little aliquots at a time. And really good question. How do you know when you put too much? You don't. Quite frankly, you don't. The way you'll know you've done too much is if, a couple of months later you start getting hard lumps, the fat dies, or you get oil cysts, or you get infection, or you get problems. Then you put in too much because the fat has died. But when you're doing it, you don't. And so you could say, if you've never had these problems, you haven't put in enough fat because you've never pushed the boundaries. And, my view is a tendency more to less flat fat. So I don't get fat necrosis or hard lumps. I don't say I not get it, but it's not common to get oil cysts, fat necrosis, and lumps and complications like that. But it's small volumes. If there'll be another surgeon next door who does big volumes, and you might say, "Oh, I want the big volume guy," because when I do it, you often have to have it done again, and it's expensive. It's an expensive operation, and you might say, "Well, I want the big volume guy because I don't want to have to keep on coming back. I want big volumes." But then the not that it's good or bad, but you're going to increase your risk of complications with fat necrosis, lumpiness, cysts, infections. Where is the point? There's nothing in theatre that tells us that's the maximum. Stop now. That's the problem. It's clinical experience, and there isn't anything that says you've put enough fat in now. So it's surgeon's experience what determines it. But I always tell people it's subtle, usually less than a cup size. Once you put some in, then you can put more in next time. And so it often has to be repeated. But it's, yeah. Gemma, I won't name the surgeon, but he is registered with both, and he offers 10% discount on every surgery to NHS staff. Oh. You know what, Gemma? People do like to help out the NHS staff, and it's all like perks of the job and things. But well, that's anyway. I don't know. Well, that's all right. Well, okay, good. He's trying to help his colleagues, which is admirable. The problem for me is once you start giving discounts and things, it's all right. But anyway, yeah. Ella. Hello, Jonathan. I've wanted to check if surgeons actually charge more if you have a hernia when doing a full tummy tuck. Depends. Now, people talk about this a lot, actually. Oh, Debbie lost a quick dot. People talk about this a lot, hernia thing. And basically, it's very common to have a small defect in the abdominal wall, a small hernia. It's very common to have divarification of the rectus muscles, or weakness between the rectus, the six-pack muscle, which gives a bit of a bulge. It's not really a hernia. So it's very common to have a little bit of this or a little bit of that. They're not really and they just routinely, sometimes you know about it before the op, sometimes you can diagnose it and people can have got a bulge. Sometimes you find it in the op, incidentally, you find a hernia, small hernia, but they're usually small hernias. And as you often repair the muscle together, pull that rectus muscle together, you repairing that hernia is just part of it. So it's incidental. So usually 99.9% of the time, any sort of hernia or weakness in the abdominal wall is repaired and is part of the surgery and is not charged more. If you have had previous abdominal surgery, or if you've got a proper big hernia, a big thing that sticks out, and you might need to have mesh, and you might need to have the general surgeons involved. And, you know, if you've got a problem, then you might have to have charge more. If you, well, I shouldn't say, because this is what, you know, everyone's different, but that's my view on it. I think it's very common to have a sort of little hernia, which is usually just repaired and is part of it. And I don't, you know, usually wouldn't be charged more for that. But you know, if you did have a big hernia that was, you know, going to be part and parcel of the operation, part of the operation was repairing this hernia, and it might need some techniques to repair it and meshes and things like that, you would certainly be charged more, especially if you need a mesh or something like that, because that's expensive. The mesh itself is expensive. So so yeah, Debbie's lost me, but then she says she's lost connection. That's good. So I thought you'd lost me. So if you watch it back, Debbie, you might still have lost me because I went on about abdominal liposuction. I don't know if I made it clear. That would be great. What would be great? What's that referring to? Oh God, I'll keep track of this. Lost connection. Sonia, I exercise a lot but can't get rid of flabby bit. That is because it's skin, Sonia. It's skin, and this is the problem. People exercise, they lose weight. It's not weight loss. So the flip side is when people have got a lot of weight, you're not a good candidate for a tummy tuck. You're a good candidate for, sorry, when you've lost the weight, when you're fit, when you're healthy, when your muscles are strong, but you can't bring those muscles together and you can't get rid of the skin. That is the problem. That's why when I'm a blog post back in the day, there'll always be a need for tummy tucks, you know, because you can exercise as much as you like, but you don't get rid of the skin. That is the problem with tummy tucks. Well, not the problem with tummy tucks. That's the reason people need tummy tucks. But you're not alone on that, Sonia. Right, right. Mel, I've lost nearly 8 stone. Look at this, Mel. You are beating Sonia. Sonia's lost 6 stone. Sonia, beat that. Mel's lost 8 stone. Right. Comment if you've lost more than 8 stone. No, that's what the YouTubers do. Don't comment if you. I've just been watching. Sorry, I've just been watching it with my children. They've been watching all the Fortnite videos. Smash the thumbs up button. They all say smash it. I don't think there is a thumbs up button on this, is there? But anyway, Mel, I've lost nearly 8 stone, which is awesome. Mel, you must be unrecognizable. Well done. And have really loose skin on my arms. Is there anything that can be done? Yeah, I mean, it's interesting. This. When you talk about body contouring, there are different operations, and the classic situation when people have lost a lot of weight: abdomen, breast, arms, thighs, face. Yeah, Sonia, good for her. Absolutely, I agree. So, and the and some ops are more common than others. And I think what I normally say to people is that if you go on the internet and things, you'll see an awful lot about mastopexy, breast lifts. You'll see an awful lot about tummy tucks. You won't see much about arms and thighs. You know, when you look at people's websites and stuff, and our website as well, there's probably not much about arms and thighs. And the reason for that is that not really, I wouldn't sort of say pushing it, because we don't really sort of push anything, but you know, the problem with arms and thighs is the scar, because all of these things leave a scar because they all removing skin. As I say, the problem is the skin. I mean, fat is removed as well, but fat you can remove with liposuction, but it's the skin you need to remove. The skin you need to tighten as well as the fat. But it's skin. So when you're removing skin, you leave scars. Now, when you do mastopexy, the scar's hidden in a bra. When you do tummy tuck, the scar's hidden in your underwear. So it's a really good scar. When you do an arm lift or a thigh lift, especially the thigh lift, the one I'm talking about, where you make that big scar down the middle, there's a big long scar. When you do an arm lift, there's a big long scar. Big long scar down your arm, all the way down your arm, all the way down to your armpit. So it's yes, something can be done, Mel, and you know, it's, as I say, it's usually skin. It's usually not. People often think I want liposuction, but you've done the liposuction yourself. You've lost 8 stone in weight. You've lost the fat. You got rid of the fat. It's the skin that's the problem. But if you're going to have the skin tightened, you have to remove the skin, and that leaves a big long scar. We aim to hide the scar, so you aim to hide the scar in a neutral position. So when you put your arm out from the front and from the back, you can't see it, but you put your arm up, it's there. It's there. It's on the inside, you know. So you put your arm in the air, it's there. You wear short sleeve shirts, it's there because it goes to your elbow. So it's about being aware. Yes, something can be done. People don't like the contour. The contour can be improved, but it is quite a long scar, and that's something you have to really think about, because you might say, oh, I can't wear short sleeve shirts because I don't like my arms, and then we give you a big long scar, so we make the contour a lot better, but then you might still not want to wear short sleeve shirts because it's easy for you to say because you don't like the scar. So you have to balance that. So something can be done. It's an arm lift or a brachioplasty is the sort of medical term, but it's actually an arm lift, and but it's something to be considered because it is a scar that would be there. Ella, if I had a muscle repair, would that stop future hernias? No, no, it wouldn't, Ella. There's two types of hernia. Getting into there's what we call congenital and acquired. Congenital hernias are you born with a weakness, inguinal in the groin, femoral, and then acquired hernias are hernias which are due to weaknesses or due to raised intra-abdominal pressure. So when you get pregnant, you can cause a hernia. If you have surgery, if you have any surgery to your tummy, there'll be weakness in that abdominal wall. So any weakness in the abdominal wall can then bulge out and cause a hernia. So if you have an abdominoplasty and the muscle brought back together again, you could still get a hernia somewhere else on your tummy. So it wouldn't really stop you from getting a future hernia, I'm sorry to say, although that hernia would be fixed. Good for her. Yeah, I would agree. Good for you, Mel. You've lost 8 stone. That's fantastic. And good for you too, Sonia. I've got to say, six stone is amazing. These are unbelievable weight losses. I like changing, and I'm sure it must be not easy at all to lose that sort of amount of weight, which is fantastic. Debbie says, if we are talking hernia, would a hiatus hernia be repaired during a tummy tuck, or would it not make any difference? It would not make any difference, Debbie. A hiatus hernia is a hernia of your esophagus, your feeding tube, or not your feeding tube, your gullet, I suppose they call it. The gullet goes into the stomach and it goes through the diaphragm. So it goes, your esophagus goes into your stomach and it goes through the diaphragm. And a hiatus hernia is the esophagus poking up through the diaphragm, intra-abdominal. You can't see it. You can't see a hiatus hernia from the outside. It's intra-abdominal, and because the junction between the esophagus and the stomach is then pulled up through the diaphragm, you get reflux and heartburn and things like that. So yeah, it's inside the abdomen, and it wouldn't do anything to your to a tummy tuck. It would not be addressed, so it'd be the same. Sonia, it's better than having loose skin, and it might be better than having loose skin. And we do arm reduction, Sonia, but it is something to be aware of. I don't want to just say, yeah, we can fix your arms, get really good contour, beautiful, fantastic. You have to be realistic. It is a scar, and you have to be realistic about that in order to make sure that it's right for you. Jade, I am looking into both an breast uplift and augmentation and a tummy tuck. I would like to do them separately. Is there a set way to do it, such as tummy tuck first, boobs later, or the other way around? No, Jade. I would say do what's more of an issue for you. You could do them either way around, and it's perfectly reasonable to do them at the same time, but it is perfectly reasonable to do them separately. And I would say, what is the biggest problem for you? And if you could only have one done, which one would you have done? And I'd do that one first. The tummy tuck doesn't really affect the boobs, and the boobs don't really affect the tummy tuck. So just do whatever you want to address first. There's no real reason to have one done over the other one. There's a reason if you're doing them both. When we do the surgery, we do one first, but that's just technical because of the table and stuff like that. But yeah, no, whatever you worries you or would give you the maximum sort of benefit. I would think to yourself, what if something happened between the two and I couldn't have the second one? What would I be happier having? That was my thing. Belly hernias, will they get stopped? We got to stop these belly hernias. Stop them. We need to stop the belly hernias. Belly hernias, will they get stopped? Come on, Ella. What are you on about? What does that mean? Is she enlightened? Is she enlarged on that? Belly hernias, will they get stopped? I don't know, Ella. Belly hernias will be improved if you will fix them at the time of a tummy tuck. So you mean, yeah, if it's just a small hernia or a small weakness. I think it's probably best talking to the surgeon, actually. If you know you've got a hernia, don't listen to me because I'm just talking very generally here. If you know you've got a hernia, talk to the plastic surgeon who's doing your tummy tuck and say, will this hernia be fixed and is it going to cost me more? Or probably just say, it's going to be part of it? Will it be part of it? because a guy on the internet said it'd be part of it last night. I'm really considering having my arms done. Thank you for answering my question. Well, you're very welcome, Mel. And yeah, look into it, Mel. I think we've got some photos on the website of arms, but you probably won't find much on the website, or not, well, on any website about arms. But it is a thing, arm reduction. And though, to be honest with you, the people who've had it done have been really, really happy with it. But having said that, don't do it on many people, because a lot of people want to have it done, and we say there's a big scar and all that sort of thing, and it's complications. The scar is usually like an L shape, goes up into your armpit, and healing in the armpit's often a problem and things. So we tell people about what's involved with it. So patient selection is, people who really want it and really don't like the contour and are happy to accept the scar. And actually, they're very, very happy patients, people who have the arms done. Can you change 275cc high profile polyurethane 1-year-old implants for 350-ish moderate smooth implants TIA? Helen, yes, you can. 275 high. The only thing I would say, Helen, is the whole big thing about. So, in principle, changing an implant for another implant, fine. Polyurethane to smooth, fine. No problem at all. Well, I say no problem at all. People go on about the polyurethane being hard to remove and all that sort of stuff, but it's fine. It's absolutely fine to do that. We spoke about that on the other day, about that sort of thing, but it's all a bit of a, it's fine. The only thing is, the thing that I really make a big deal of when I'm looking at implants and sizing people in implants is the width. And if you've got a 275cc high profile implant, that's going to be narrower than a 350 moderate profile implant. Now, assuming I don't know if it's going to be the same make. It might, different makes are different. But in broadly speaking, this is a bigger implant, 350, and it's a lower profile, so it's going to be wider. I don't know if that makes sense. So if you think about it, a 350, if it was a 350cc high profile implant, it would be narrower than a 350cc moderate profile implant. Let that sink in. Does that make sense? So for the same volume, a high profile implant, because it sticks out more, is narrower. So what you're doing is you're going for a bigger implant, so a bigger volume and a lower profile. So it's going to be even wider. I don't know if I made that clear. But the bottom line is the width isn't what I'm worried about, Helen. If you're going to go from a 275 high to a 350 moderate, it's the width. So it depends on the width of your chest and the width of the 350cc moderate smooth implant. So that's what worries me about that question. Going from a polyurethane to a smooth implant is fine. It's going from a the other problem that would have to be considered is the pocket, because it will be when you're putting a smooth implant in, the polyurethane implant, when you put them in, you have to make a very big pocket. When you put a smooth implant in, you have to make a pocket that just fits. So you want a pocket that just fits. So it's actually good that you're going for a bigger implant, because you're going to have a bigger. If you went for a smaller implant, it would rattle around in that pocket and it wouldn't fit, because a smooth implant doesn't adhere in the same way as a polyurethane implant. I don't know how this is. Not sure how clear I'm being here, but so that's good that you're going for a bigger implant. That is good. The only thing that worries me is the width. I worry about the width of that 350 moderate profile, but if that's quite specific, your question. So I'm presuming you've seen a surgeon and they've come up with this plan. So that's hopefully, I'm presuming they made the width, they measure the width and stuff like that. So Jade says, brilliant. Thank you, Jade. Thank you, because that is a lovely thing to say. Thank you for that. Ella says, sorry, you answered my question on my first question. Sorry. Okay, no problem. That's good. Don't be sorry. It's fine. Zoe, Mr. Butt. Is that Mr. Zoe, who said Mr. Butt? Was that you who said Mr. Butt back in the day? Mr. Butt. You and your Mr. Butt, she means thank you in advance. Right. She means thank you. Sorry, you answered my question. Oh, TIA. TIA. Thank you in advance. Oh, look at you. Right, okay, I'm gonna have to make a note of this. Thank you in advance, and Muscle Repair, MR, TIA. Got to get with it. Get with the kids, man. Get with the abbreviations. Sorry, thank you for that. So it's not TIA. It's thank you in advance. Okay. Where are we up to? Sarah. What causes a hematoma a few days after a tummy tuck? Why do UK surgeons take drains out the next day? Does this increase the chance of a hematoma? So, sorry, is that? Yeah. Sarah, good question. So Good question, Sarah. What causes a hematoma? Well, I'll tell you what causes a hematoma, Sarah. The thing that causes hematoma is bleeding. Now, when we do the surgery, it's quite a big operation of tummy tuck, and there's quite a lot of cutting, and you cut quite a lot of blood vessels and things, and you seal them all off with a little machine and all that sort of thing. So then what happens is you go back to the ward, and when you're having the surgery, your blood pressure is controlled, your pain is controlled, everything is controlled. And sometimes it's not common. A hematoma is not common. It sounds like you've had one, but it is not common. But if you have a hematoma, then you go back to the ward, you get a bit of pain, your blood pressure goes up a bit, you cough, and there might be a little blood clot that was just teetering on a little blood vessel, and it pops off and it bleeds. And that causes a hematoma, and the blood collects inside. And to be honest with you, a hematoma can happen with drains in. People often say, "Oh, if you'd left the drain in longer, or if I'd had if you don't use a drain and a hematoma, if the blood is going to bleed enough to cause a hematoma, the drain is not going to stop a hematoma. It's just going to make it come out of the drain. You still have to go back to the theatre and have it washed out. So a hematoma is something that can happen, and it just happens by blood pressure going up, a fragile blood clot or something over the vessel popping off, and it bleeds, and it's everyone. I probably get about one a year. Once a year, I get a hematoma for whatever, maybe a breast reduction, tummy tuck, or something, because they're big ops. There's lots of cutting, and it just can happen. I'm sorry to say, and it's an established complication of any operation, mole, cyst, tummy tuck, gynecomastia, appendectomy, thyroid operation, any operation, you can get a hematoma. So why do UK surgeons take drains out the next day? I don't think UK surgeons, I mean, we usually leave them in 2 days, but you take them out when the drainage slows down, not really stops, but slows down really. So we just take them out when it slows down, because what we're trying to do is to encourage that skin flap to stick down. It's really for seroma, really, the drain, and it's to encourage those two skin flaps to stick down. So when the drainage slows down, then you take the drain out. Does this increase the chance of hematoma? Not really, Sarah. What they've done, and that's, as I say earlier, we're trying to use less drains, and certainly in breast reduction, they've done studies where they put a drain in one breast and not in the other breast, and they found that the risk of hematoma is the same, whether there's a drain there or not. So although I can understand you having a hematoma, if they took the drain out after one day and then you got a hematoma the next day, you'd be like, flipping heck, if they've left the drain in, I wouldn't have had the hematoma. But studies have said that you can get a hematoma with a drain in. And I've had hematomas with drains in. I've had a hematoma with a tummy tuck and had drains in. So, you can still get a hematoma even with a drain in. If it's going to bleed enough to swell up, the drain is not going to stop the bleeding. You have to go back to theatre, open up, and stop the bleeding. So it's something that can happen. Vivian, hello. Do you know much about B-cell monoclonal lymphocytosis? Whoa. Permanently elevated white blood count. Do you think this could be either an advantage or disadvantage to healing? Whoa. 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 Vivian, flipping heck. B-cell monoclonal lymphocytosis. Jeez. No, Vivian, I don't know much about B-cell monoclonal lymphocytosis. The white count is the real problem, or a real thing that I would be worried about with a white count would be a low white count. A low white count will make you increased risk of infection. So that will be a concern to me. In any situation where someone's got a problem with another system, so this would be a hematologist. You've got you or whoever you're asking the question for has got a problem with their blood, and so I would say that we would write to your GP and write to the person looking after your blood, so a hematologist. Or if you don't want to come for a consultation because you might think, well, if they're not going to do the surgery, I'm not going to come and pay for a consultation. Talk to the person who looks after your blood and say, look, I'm thinking of having surgery. Is that going to be okay? Or so, and that's what we would do. We write to them, and the two things we want to know is, number one, is it safe? You might say, or she might say, no, it's not safe. You're a very high risk of complications, and you shouldn't have it because you're going to get whatever. Or they might say there's something we can do to optimize your situation. I don't know if you're on treatment, I don't know, steroids or whatever. If you're on some kind of treatment, if they're in a period where you're drugs are being sort of manipulated or changed, then we'd probably rather you're at a stable position with this condition. If there's something we can do to make your condition better, sometimes I don't know about an elevated white cells. That's a little bit unusual. But if it was a low white cells, we can give you like fresh frozen plasma available. If there and if there are other problems with blood, we can have sort of blood products available to substitute to cover you for the surgery. But this is something we need an advice from a hematologist, really. So I'm sorry, Vivian, I don't know I don't know much about B-cell monoclonal lymphocytosis, but I would ask a hematologist, or preferably your hematologist, whether there's anything, whether they thought it was safe for you to have surgery, whether we should warn you about increased risks. So they might say, yeah, it's safe, but she's got increased risk of a DVT or an increased risk of an infection or something like that. And we'd say to you, look, we've got it as good as we can get, your lymphocytosis, but you've got an increased risk of infection. And then, obviously, if it's a prohibitively high risk, we probably wouldn't do the surgery. But if it's just a little bit increased, we say to you, look, it's up to you. How much do you want the surgery? You have got a high risk of infection. Balance it up. So sometimes it goes like that. You just got to think pros and cons. But yeah, we would do it in combination with your hematologist or your GP or whoever's looking after your blood. Zoe, double thumbs up. I'm loving it. Helen, makes perfect sense. Learned something new about the pocket, so that's fab. Excellent. Thanks very much. Haven't been back to my surgeon and don't plan to. She wasn't very approachable at all. Yeah, Helen, you've got to be a bit careful with the pocket, particularly going polyurethane to smooth. That's sort of like two extremes, really. A smooth implant doesn't adhere at all. It's really real hand in glove pocket, because that's just going to wobble about all over the place. So you want the pocket of the right size. So they may have to do some work to the pocket. They may have to do what's called a capsulorophy. Well, they probably do a capsulectomy, but anyway, they might have to close down the pocket in places in order to, and it depends on your shape, if your shape's okay now, or if you need to have something adjusted to your pocket, maybe put the implants more medial or more lateral, or if there's a problem with the position of the implants. It is much more difficult to position smooth implants. It's a difficult way you're going polyurethane to smooth. It's a lot easier going the other way, going smooth to polyurethane, because polyurethane implants stay where you put them. So you can have a big pocket and you can place them and they stay there because you get tissue ingrowth into them. Smooth implants don't. So you'd have to adjust your pocket and make sure your pocket is right. And that's going to be a difficult operation, Helen, going from polyurethane to smooth. And you have to, and I would worry about the width of that smooth implant because it's a moderate profile and it's bigger, so it's going to be much wider than your current implant. Sarah, just had mine drained. Oh dear, sorry to hear that, Sarah. But usually when you have it, I think with this here, we're back on the hematoma now. So yeah, I'm sorry to hear that. Oh, here we go. Just had mine drained. Thank you. Yes, I had 0 blood the next day in the drain, but over the next few days, my stomach filled up and we got it drained within the next week. So all good. Yeah, well, Sarah, this does happen. And I can't say that it hasn't happened to me because it has. And it is a bit unusual. They had 0 blood the next day. Because was it you that said take them out the next day? So that I don't take them out the next day very often. Very rare for me to take them out the next day for a tummy tuck, because what I try and do is get you up and walking. Because often when you get up and walk, it bleeds a bit more. So I normally take them out day 2 personally, or day 3 sometimes if there's a lot in there at day 2. That doesn't help you, Sarah, does it? Because you just had a hematoma, so taken out day 1. But anyway. But sometimes when you get up and start walking and start moving about, it bleeds a bit more. So, yeah. So, right, we're back into the questions here. Here we go. We've got a question here. How long after removal of birthmark on lower stomach near hip can patient do sport? That's specific, isn't it? It's specific. Removal of birthmark on lower stomach near hip. So anyone out there, if you've got a birthmark on your lower stomach near hip, this question's for you. So this is all for those patients out there. If you've got a birthmark upper stomach nowhere near your hip, turn off now because this is not relevant for you. But if you've got a birthmark on the lower stomach near your hip, I'm talking to you. So yeah, for anyone who's got a birthmark on the lower stomach near hip, when you can do sport is when the wounds, gentle stuff once the wound's healed. The skin will be healed in 4 days, best case. So the skin gets healed really quickly. So call it a week. So the skin will be healed in a week. but it's not really strong. And the problem with it, you really worry about any scar that crosses a joint. So you say near hip. So the question is, does it cross your hip? Does it, when you move your hip, does it move? So if it's on your abdomen, what did you say? Lower stomach. So if it's on your stomach, sort of above your hip crease, then that's less of a thing than if it's crossing your hip crease, because every time you move, you're going to put that scar under tension. So I'd be more worried about moving if it crosses your hip crease than if it didn't. Same if it was elbow, arm, shoulder, anywhere. But I would say I'd leave it a couple of weeks before doing anything. Before doing, I'd say walking and stuff is good. Probably straight away. You don't want to get DVT. You don't want to get a clot in your legs. So walking and everything like that straight away. And exercise other parts of your body after a week or two, because you don't want to get it hot and sweaty. So you don't want to go exercising too soon. So a week or two, you can start doing exercises of the rest of your body. With regards to moving your leg and moving your hip, it's sorry, you hear some? It's a bit dark in here. The lighting right today. I'd say 2 weeks you can start doing gentle exercise, and then standard really thing is 4 to 6 weeks before doing anything too strenuous. And just to have if it hurts, if it starts to pull, ease off. And then I would do exercise on your own. Sport is a bit different. That's a bit nebulous. Sport depends what it is. If it's chess or fishing. No, I'm assuming it's some kind of running sport and contact sport and that. So I'd say 2 months for contact sport and stuff, and then if it hurts, then ease off. But you need to talk to your surgeon about how tight it was, how wide was the birthmark. If it was closed really tightly, they might want to leave it longer. And if it's had any problems with delayed healing, you might want to leave it longer. But broadly speaking, I'm saying a couple of months start before you want to ease into it, if that's okay. Hold on, what's going on here? Sarah, tiny bit of, oh, I had 0 blood the next day. Tiny bit of blood was in the drain, I suppose. Yeah, but there's always a tiny bit of blood. You take it out if there's a tiny bit. Mel, sorry to go back to the arms. It's okay, Mel, no problem. We go back to the arms. Would they be done at the same time? And how long do you recommend being off work? Same time as each other, do you mean, Mel? Or same time as something else? Are you looking at something else? So if you're having 2 arms, yeah, you do them both at the same time. Well, in the same operation. And it depends on what you do for work. If it's an office work, I'd say 2 weeks minimum, maybe 3. If it's activities, I'd say 6 to 8 weeks. If you're, I don't know, working in B&Q or something, if you're doing heavy lifting, 6 to 8 weeks. But 3 weeks is probably normal, I would say, for driving and getting back to an office work. You probably still feel a bit sore. Your scar's going to be red and active and firm, and you'll have numbness and all sorts of things after 3 weeks. But I'd say 3 weeks you sort of be all right. Sort of in general terms. Sarah Strong did walk about, but yes, was the next day. Yeah. Vivian, thank you for giving up your time to answer questions. Says a lot about your work ethic. Well, thank you. Can you tell my wife that? Yeah. Anyway, she's all right with it, really. Nurse. Oh, your work is a nurse. Okay. Yeah, well, you don't want to go transferring patients and things, Mel. So 3 weeks if you can do. We sort of normally do it like a sick note and say 3 weeks off, followed by 3 weeks light duties or phased return. Now you might say I can't do light duties, in which case it's 6 weeks off. But if you can do light duties and sit in the office and things like that, but you don't want to be transferring patients and things when you've had your arm, because it's closed under tension and stuff. So I'd say 6 weeks really before I don't know if you do transfers and things like that or anything too much with your arms. Can I ask my surgeon about complications? So I've got the whole question here. Is it acceptable to ask the surgeon in a consultation the number of patients that have had complications such as sepsis, necrosis, and major infections? And if so, how should a person approach the surgeon with this question? How should we word it? Right. Okay. Well, yes, it is completely acceptable. One thing I would say is I think you have to know everything before you have surgery, and you have to know these questions. And if obviously you need to be fully informed of all the bad things that can happen, but I wouldn't dwell on the things like sepsis, terms like sepsis, necrosis, major infections. These are really rare. Well, you have to ask your surgeon, but they're really rare. I know if you watch TV you think they happen all the time, but they are really rare. And what I would say, so the question is saying, is it acceptable? Of course, it's acceptable. It's your body, and it's your, you are putting your body in the care of someone else. So you want to know this stuff. You want to know qualifications, complications, all these sorts of questions. Um, and what I would say is that it's a bit like me, the accountant thing. I got that problem. I don't know if you were here earlier with the accountant. Well, actually, this is not a live question, is it? This is someone who asked a question before. Okay, so the thing that is awkward asking the question because I saw another accountant and I had to say, "What's your qualifications?" And it's awkward. I feel, you feel awkward asking that because you see everyone looks smart and you think that. But what I would say that if someone has got really good qualifications and has got low complication rate and is confident with their ability, they will be quite happy to talk to you about this. So I would say if they are a bit, I understand you will feel awkward about it. And I get that because I think I would feel awkward about it if I was having surgery and I said to the surgeon, "Can you just ask you about your complication rate?" Um, it is awkward, but I think, it's okay. And I think if you are, the way that I look at it is I will, our job is to tell you what's out there. Our job is not, we're not selling stuff. We're not selling, well, even if you are selling stuff, even if you are selling a TV, you don't want to make out stuff that's not right about the TV because if they get it home and it doesn't actually connect to the internet or doesn't do something you thought it would, you're going to be unhappy. You're not going to recommend that TV salesman. Maybe a TV is not a good example. But the point is, I will say to people, like infections are very rare. So it's hard to give an infection rate because it's just rare. When you think about things with breast implants, it's if to have a cosmetic augmentation get infected, it's just never happened. So it's because it's never happened. You can't give a percentage, but it does happen. But it's a small percent. So it's not very helpful. It does happen to people, but so rates are difficult. But like for instance, so there's two things really with this. There's complications and revisions. Complications are things that happen within 30 days. Revisions are things that happen after 30 days. So like people ask me about that, and I've got a seven. Well, last time I looked at it, I haven't looked at it for a while, but it's about 7% revision rate, which is average. And but that's not all necessarily all bad because you're doing little nips and tucks and things like that. Complication rate is different, and I think it's reasonable to ask it. But the problem in plastic surgery, although despite the programs, you would see it is rare. As I say, you get about one hematoma a year. I've had one seroma in about 10 years from a tummy tuck, no implant infections. So from cosmetic breast augmentation, I'd give a rider there. When you do reconstruction, it's a different thing. When you start doing breast reconstruction, people have radiotherapy, then you do get infections, you do get complicate a lot more complications with that sort of thing. But for cosmetic surgery, infections are rare, and it can be difficult to give a rate of complications. So I normally say, look, get about one hematoma a year, and seromas are very rare. Necrosis is a sort of quite an inflammatory sort of term, but skin death and skin not healing up. You can call it necrosis if you want, but a little bit of wound dehiscence, wound not healing up is not. It's a potential for any of this surgery because it's done tightly, but usually it doesn't need any more surgery or anything. You're just using these dressings. So I think it's fine to ask the questions, and I think if you see how the surgeon handles it in a way, I think they might not. Don't be surprised if they don't give you tangible answers. If they said it's 2%, I'll be thinking, okay, that's quite high. If because it's less than a percent, it's usually pretty low. These sorts of problems, so they might not be able to give you a percentage because I can't give you a percentage for sepsis, necrosis, and major infections. Because when did I last have a sepsis, necrosis, or major infection? It it happens, but it's like 5-6 years ago. So it's a really difficult question to answer, but I think I would say you got to see how they answer it. That's the thing I'd be looking out for. And if they feel guarded, if they make you feel uncomfortable, then I think, oh, maybe they're not that sure of themselves. How you should word it. I think it just, you got to say, look, you know, what's the chances of me having the complications? Do you get many of these complications, or I don't know. Yeah, it's a difficult one. It was me that asked. Oh, it was you that asked this one, was it, Rachel? Yeah, it's a difficult question, Rachel, but I think it's absolutely fine to ask, and I would encourage you to ask, and you're perfectly within your rights to ask. And to be honest with you, we're encouraged to encourage patients to ask questions, you know, complications thing. And and the other thing, I think it's fine to see different surgeons and things like that and get different answers and make a judgment, because you'll click with one and maybe not the other, sort of thing. Yeah. Oh, Sarah's got a gross question. Sarah, slightly gross question. My muscles were split by 10 centimeters. Wow. With an umbilical hernia, no mesh. Yeah, an umbilical hernia is usually really small. No mesh used to repair. In time, with good careful exercise, can these muscles be in as good shape as if they never split? Just wondering. Yes, Sarah, that's not a gross question. God, there's some gross questions in my time. That's not one. Sarah, your muscles weren't split. I don't know if you appreciate what that means, the muscle split. So your muscles weren't split. Your muscles were well, they were just apart. So your six pack muscle, there's a thing between your six pack muscles when you sort of not had children and not put on weight. The two things that do it are stretching the tummy with children weight. So I'm doing this because of the mic. There's just a thing called a linear elbow. It's a very fine line between your six pack. So if you look at sort of an anatomy specimen, or if you look at someone with a six pack sort of thing, they've got their six packs are right next to each other. When your intra-abdominal pressure is stretched, those six pack muscles go apart, and what you do is you bring them back together again. So the muscles aren't split, the muscles are fine. That's the problem with some people who like go and do all the gym and all that sort of stuff, and they get really fit and they get really strong muscles, but if they're apart, they're still strong muscles apart. The gym can't bring the muscles together again. And what we do is we close that space. It's called divarification of the recti muscles. It's not a hernia, it's a divarification. It's a split, it's a splaying of those muscles, and we bring those two muscles so they sit next to each other. So your muscles aren't split, it's just the space between the muscles is widened, and we narrow that gap. So that gap has been narrowed between your muscles. So you can go and do the gym and do sit-ups and all that sort of stuff, well, once you're all healed from your tummy tuck, and get strong muscles. And so, yeah, your muscles can be in as good shape as ever, now that they're back together again. So yeah, absolutely, your muscles haven't been damaged or anything like that, or the muscles haven't been split as such. It's the space between the muscles that has increased. I hope that's so. Yeah, you'll be fine, Sarah, so don't worry about the 10 centimeter thing. So can you talk a bit about seroma, please? Causes, cures, etc. So yeah, seroma is fluid collection, and it's not blood, it's wound fluids. It's watery yellow fluid which collects in any time anytime you have a surgery with a space. And the common areas are, well, for cosmetic surgery, I guess it's a tummy tuck is a common area. For sort of breast reconstruction, which is the other sort of thing that I do, is used to do, really. I don't do so much reconstruction these days, but it's in the back, where you take a big muscle from the back, the lat dorsal. You take a big muscle and leaves a space, and anytime you have a space, that space can fill up with wound fluid, and that's a seroma. And so causes is just the fact that there's a space, there's a raw surface, because you've cut, as I say, you have to undermine it when you do a tummy tuck. When you do a tummy tuck, you have to undermine it to close it. When you do the lat dorsal, there's a space because you've removed the muscle, because you've used the muscle to reconstruct the breast. So you've got a space where that muscle used to be. So anytime there's big spaces, there's sort of raw surfaces, and those raw surfaces can ooze wound fluid, which is the serous fluid, and that ooze can collect and form a seroma. And as the seroma collects, the two wound sort of surfaces can't close. It can't heal up. So it's a bit of a self-fulfilling prophecy, really. That's why it's good to have it. If it's dry and it sticks together, then it's stuck. But once you get a bit of a seroma, then it's like it can't stick then. And so sometimes you don't always have to drain it. It will get better on its own. It will reabsorb on its own if it's not a big one. But if it is a big one, you often have to put a needle in and drain it. The problem is when you drain it, you leave a space there, and then it can come back again. It usually does come back again, but it usually comes back less. And so you have to sometimes repeatedly drain them. Each time you drain them, there's a risk of introducing infection. So you don't want to drain them too often, but at the same time, you don't want to leave people with sloshing about fluid all over the place, which is uncomfortable, and which is going to take ages to get better. So if it's a big one, you have to drain it. So that's the cure. That's the cause. The cure is really just to drain it and then compression as well. So if it's the tummy tuck, then either the garment, if you've been given a garment, or big pants, the big pants, like the figure hugging pants, those can help, just a bit of compression to help sort of close down that space. And as I say, there's things we do like the drains and the quilting sutures and glue. These are things we do in theatre to try and close down that space. But obviously that's not helpful for once you've got one. It doesn't really cure. That's more for prevention, I guess, than cure. So curing is just time. They usually get better on their own, and if they're big ones, draining it. They used to do things like inject stuff in to encourage the thing to stick down, but we don't do that anymore. So we just, well, I don't think many people do that anymore. We just usually just drain it. Sarah, I should be on this morning. Thank you, Sarah. Yep. Available. Talk to my agent. Available for this morning and other television slots. I haven't got an agent. You just Facebook me. Thank you. So following on, this is following on here. Would you kindly add helping in Would you add helping in edema reduce while you discuss seroma this evening, please? Also, how to effectively suntan after surgery without hurting the scar. I'm worried about my upcoming holiday. Tummy will be fine because bikini will cover it, but belly button and back knee scars are a little problematic. Okay, so we'll do the edema thing. How do you do edema while addressing seroma? So that's a distinct thing, edema and seroma. So seroma is where you have a space. As I say, tummy tuck is the classic, and the space fills with fluid. Edema is swelling, is soft tissue swelling. So when you bang your arm, when you fall off your bike and you bang your arm swells up, and that's tissue swelling. That is not seroma. It's like when you have your breasts done. It's all like out there. That's not seroma. Seroma is free fluid that you can put a needle in and drain off. You can't put a needle in and drain if someone's got a swelling. You've got soft tissue swelling because it's just in the tissues. It's not free. It's not watery free fluid. It's just all the tissues are waterlogged sort of thing. So edema is different to seroma, and edema happens after any surgery, and it's just sort of a generalized soft tissue swelling. Seroma, you can often feel the slosh of the water as you move. It sloshes about. It's like literally water sloshing around. Edema, you don't have that. It's just generally swollen. Everything feels, with your face or your toe after liposuction or whatever. So, so what's the question? How do you reduce edema? So basically, again, it's compression. It's trying to take it easy, but at the same time, you don't want to give yourself DVTs and slow down and give yourself chest infections and all these sorts of things. So I encourage you to mobilize and move. There's always a balance. You don't want to overdo it. If you overdo it, you will make it swell more and you'll make the edema worse. But at the same time, if you don't move and get out and about, you will, or your healing will take longer. You'll feel miserable and you're more likely to get DVTs and things. So I think the balance is along the side of getting up and about and moving around. But if you feel that it hurts more, if you feel that it swells up more, then take it easy. Listen to your body, and it's your body saying you're doing too much. So listen to your body, and if you find your body swelling up, then or whatever your body part of your body is, then take it easy. And compression is the other thing for edema. So again, if it is tummy, you compression pants or the binder. If it is breast, then a supportive bra, and if it is another part of the body, just some kind of compression, like the compression hugging tops that rugby players wear. So if it's a gynecomastia or something like that, so compression is good. I'm worried about hurting the scar. So this patient has had a tummy tuck. She's also had some excess tissue removed from behind the knee. So I totally get. Now I think the scars have faded pretty well, to be honest with you. So I think the main thing about the scar is while the red is red and obvious, you mustn't get a tan on it. Now, as you say, it's easy to cover the bikini one, or it's easier to cover the bikini one, but the belly button one is the problem. We try and hide the belly button one within the belly, inside the belly button. So it's often not on the front. So it's sort of in the shadows. Try and make it sort of in the shadows. So hopefully it's not too badly affected by the sun. And I think your scars have settled pretty well. I think they're sort of skin colored, are they? If they're not, if they're still a bit red, the scars, then yeah, you have to just wear like a swimsuit. You shouldn't get a tan on it if it is red. And certainly if you can sort of see it from the front, then you shouldn't get a tan on that skin. So yeah, you're absolutely right. You have got to be a bit careful about that belly button scar. But as I say, try and hide it on the inner part of the belly button, and also once it's faded, you can do what you want. But if it hasn't faded, if it's still quite red, then you shouldn't get a tan on that bit of scar. And also the same thing about behind your knees. They've faded. I think no, actually, maybe one of them's still a bit red. But anyway, the good thing about behind your knees is that sort of scar's hidden. It's in the sort of darkness. It's in the shadows. So I don't think that'll be too bad. But I would just be a bit aware of it and just don't lie on your front for a long time and get a scar on that. Maybe put a towel over the back of your knees. But yeah, just be a bit careful with these scars while they're red and obvious, which is the first 3 to 6 months, can take longer. So you've got to be careful with all this. And yeah, if you have still got some red scars, don't get a tan on them while they're red, because you'll lose the scar, you'll use the tan and the scar will stay red. So that is a good question, and it is something that you need to be aware of and just protect them. And once they're faded, you can do what you want. You get a tan on them, no problem. But until then, just be a bit aware of it and try and modify what you wear and how you cover yourself. And have a lovely time, because it's going to be a great holiday. Lucky you. Look at the rest of us stuck here in all this weather. So that was a good one, wasn't it? Fantastic bit of engagement there. So thank you all for that. I'm out. I'm going to declare myself out of questions. And yeah, I'm going to check myself out. If there's no other questions in the area, I don't know if anyone's still around really. 8:30 at night, Thursday night. Don't know what you think of Thursday night. I only did it because I normally do it on Tuesday, but it was away on Tuesday night, so I don't know. Can do it Thursday night if you want, but anyway, probably go back to Tuesday just to keep a bit of consistency. If you've got any questions, hi Rachel, stalwart supporter Rachel. Thank you, Rachel. Keep the questions coming. And and thank you, Mel, and congratulations again. And yeah, if you have any questions, please do Facebook me or email or whatever you want. Just get them to me, and I will do them next Tuesday at 7. I think we're back on a Tuesday. Should be. I think Tuesday. Don't think I'm doing anything crazy on Tuesday. Thanks, Zoe. And so Tuesday night at 7 o'clock, I will see you then. And I will check out of here and have a good evening. Have a nice dinner and whatever you're going to do tonight. Bye. Oh, thanks, Sarah. Thank you.